We have a few people online, and so I think it's about time we can get going. So I'm Harry Hockheiser. I am the director of the MIDAS Coordinating Center. Folks might be used to seeing Wilbert in this position, but Wilbert has moved on to another position at the National Institute of Allergies and Infectious Diseases, so we won't be seeing him in this role anymore, although I'm sure we'll be seeing him around in his new position pretty soon. Today for our MIDAS webinar, we have research from the MIDAS Latin American Network, and we have two presenters speaking. I'm going to introduce both of them, and then we'll have the speakers present in order. Maybe a little bit of time after each for questions, and then we'll save time at the end of the hour for any further questions. So the first speaker today is going to be Daniel Balela, who is a research scientist at Fundação Oswaldo Cruz in Brazil. He is the head of department in the program of scientific computing and vice chair in epidemiology. Dr. Balela holds a degree from Columbia University. His research interests concentrate on mathematical epidemiology, modeling of dynamics and vector disease populations, and applied methods on disease surveillance. He's recently worked on the epidemiology of malaria, transmission of arbovirus, including seasonality and climate effects, and models for understanding the impact of SARS-CoV-2 infections in populations. Our second speaker, Dr. Pamela Martinez, is an assistant professor of microbiology and statistics at the University of Illinois, Urbana-Champaign. Prior to that, she was a postdoctoral fellow in the Center for Communicable Disease Dynamics at Harvard, and has a PhD in ecology and evolution from the University of Chicago. In addition to her most recent research on SARS-CoV-2, she is interested in understanding how climate factors shape the population dynamics of infectious diseases and how pathogen diversity interacts and interferes with public health interventions. So we're going to hear a little bit about COVID and related developments from areas outside the US, which I think is something we can all agree is pretty important, even for those of us who are here in the US, and I'm looking forward to hearing what Dr. Balela and Dr. Martinez have to share with us today. So with that, Dr. Balela, please begin.
Thank you very much, Harry. Thanks for the invitation. It's a great pleasure to present in the MIDAS seminar. So let me share my screen here. It's, maybe I should switch the mode. Is this? You're
looks fine.
Seeing the full screen?
Yep.
Okay, good. So I'm going to talk about some of the challenges that we have been exploring in the mathematical models to evaluate the epidemiology of malaria in the Brazilian Amazon. So the topics for this session are shortly described on the perspective of reducing or even eliminating malaria in Brazil. And we have had some recent setbacks, some of the incidence increases after 2015. And so I'm going to discuss this in a little bit. And some important aspects for the modeling, specifically the differences between Plasmodium falciparum and Vivax. And this brings the possibility of recurrences in the case of Plasmodium vivax, the treatment, and so they discuss lack of adherence of treatment, and then also drug resistance, and also some future possibilities. So let me start describing, and this is quite complex. So we'll start with the cycle of malaria, and here is showing for Plasmodium vivax. So it's transmitted, both of them, Vivax and falciparum, transmitted by Anopheles mosquitoes, and it's a quite complex cycle. And let me just show some of the details. First, upon infections, the parasite will develop into the different forms or stages in the body. So I'm showing here first the human liver stages, and then later they will get into the blood. And so a person might develop some symptoms and then has a clinical case of malaria to receive treatment. But the thing is that the hypnozoites, they can stay dormant. This is in the case of Plasmodium vivax. They can stay dormant in the liver, and so we might have some specific episodes. A person can have multiple episodes of clinical malaria, and this is something that we should model when we talk about the transmission of malaria. So it could have some initial infections by mosquito bites, most notably the Anopheles duralingi mosquitoes in the case of Brazil. And we can have these later episodes, like recurrences in the cases of failure of treatment, and later and also relapses in the case of the failure of the adherence of treatment, and even drug resistance. And an individual might even have other reinfections upon other mosquito bites. So in order to put some perspective, let us see how malaria is still present in the world and in Brazil. So I've taken this data from the Malaria Atlas. And so here I'm showing the incidences, the number of cases per 1,000. And on the top, I'm showing the curves, data in the cases in the whole world. So for Plasmodium falciparum. So globally, most of the countries, especially in the African countries, falciparum has higher incidences. And then when we see in the bottom here, the case for Plasmodium vivax. But in Brazil, it's the opposite. By contrast, in Brazil, most of the infections are due to Plasmodium vivax. And also cases are concentrated in the northern region of Brazil, the area known as the Amazon Basin. The surveillance in Brazil registers clinical malaria, and let me say it's hard to distinguish from the notification data the cases that the multiple episodes that I was talking about, to distinguish recurrences, relapses, and reinfections, because each episode is registered as a single entry. But we had some strategy to evaluate those cases. So this first plot is showing the weekly number of cases on the top. On the left side here on the top, the vivax cases that I had just said a majority. And so we can see a lot of seasonality, and this is something that we observe. But over time, from 2014 to recent years, such as 2019, as I said, and vivax is increasing the proportion, and this proportion is showing on the right here, and it has been even increasing over the years. As I had already said, the cases are concentrated in Brazil, so this is shown here on those maps as for the darker areas and the higher incidences, on the left for Plasmodium vivax and on the right for falciparum cases. So to describe from looking at some cities with very high incidences to intermediate and to the low incidences going from the top to the bottom, this is like showing the incidences over the years on the left. And on the right, I'm showing the age and gender epidemiological profile of these cases. And like when we have high incidences, most of the cases are concentrated on children, early ages, and especially children. And when we have intermediate to low incidences, most of the cases in men, so very related to occupation, because they go out for some work, and this is like what's happening. And so as we have a lot of diversity in the terms of low incidences, intermediate, and high incidences, we observed some, for some years, these high concentrations of cases on the order of the 80%, 20% rule, like 80% of cases in 20% of cities. And I'm showing here in these plots a measure of how unequal this is, and then applying a measure, which is the Gini index, also better known to measure wealth inequality, but then showing here that over the years, as this measure has been increasing, so heterogeneity is increasing over the years. And what happened during those years? As I had described earlier, so the incidence has been decreasing. So as the incidence has been decreasing, a lot of heterogeneity, and so this is something that we have to think about when we consider the goal of reducing or even eliminating malaria. So this is what I just described. It's the first message, the first very high degree of heterogeneity in terms of incidence across cities. So let me show here for some cities a statistical model that we did applying like spatial and temporal effects. And so this model is, if you just apply for to train, let's say we train with data until 2015 and then try to see what the model will tell us about after 2015. So we had some predictions, let's say from 2015 to 2018. And we can also explore to try to understand the effect of some other explanatory variables I will talk about in just a little bit. But what happens is that for some states, for some of the states such as this one, the Amazonas, so if we train the data until 2015 and then try to observe 2016, 17, 18, the model it does pretty well, but for some states, well, the pattern has changed a lot. That well, the model is just not capturing, and then we can try to put some of these other explanatory variables, such as the proportion of occupation in some fields, deforestation, and others. And it turns out that multiple factors were contributing to the recent increases in the number of cases. In some states, it was more like deforestation, whereas in others was a mix due to variation in the occupation areas. And it's not shown here, but there is also some of the lack of investment in control programs, and in some states, even like importation of cases due to human migration. So let me now change and talk about drug resistance, because efficacy in treatment has a great deal also on controlling transmission. And the regular treatment involves a combination of both chloroquine and primaquine to treat both stages, the blood stage and the liver stage. And attention should be given to the primaquine, which might require 2 doses on either a 7-day or 14-day regimen. The issue here is that infected people with symptoms will look for health assistance and they will start treatment. But if they do not maintain adherence of treatment, then they will clear hypnozoids. They will not clear hypnozoids, and they have significant risks of relapses later in life. So these plots are showing like for the predicted probabilities of recurrences that we explored after analyzing from the notification data, and showing these predicted probabilities for several age ranges. So we analyzed this, and we can observe that, especially for the young ages, this is not so high recurrences, but still significant, and even more so for the young ages. So this is something that could be related to some failure to treat, even due to the fractional dose of chloroquine that's given to the young ages, to the children. And these short time recurrences, they varied a lot in the Amazon, and these maps, they explore these variation as well. And we also did like a compartmental model for analyzing the risk of emergence of drug resistance, and comparing both falciparum and Vivax. And this diagram, I will not have time to go over all of the details of these diagram, but let me just say that I would highlight that we maintain separate compartments for both a sensitive and resistant strain. And we also have compartments for the post-treatment that then we can simulate the relapses for multiple episodes for people. And this is showing for the Vivax. We also have I'm showing here the more complex one because for the falciparum is much simpler. And the strategy here was to compare the basic reproduction number and also according to some parameters and also to explore some simulations using the time for resistance to emerge. So these plots here showing are not, I'm showing the blue curve for the sensitive strain and the resistant strain in various colors where I vary the resistance cost. So we observe then that what's happening here, but let me just say that even as the resistance cost increases and are not decreases, but it is still above 1. So this is something that I should point out. And a sensitivity analysis that we did exploring several of the parameters in the model also pointed out that the resistance cost was the most influential parameter in this case. And when we compare the proportion of sensitive strain and resistant strain and analyze the time for resistance to emerge, so here showing the proportion for both over the years, and this is a simulation. So in the case of falciparum on the left, it takes some time, but in the case of Vivax, it's a much longer time. And so this is because early transmission, even before treatment, that for the sensitive strains that maintain them in the mix and makes the emergence of resistance even slower in the case of Vivax. And so a nice project lately that we did modeling the impact of a new drug, the tafenoquine. It's very interesting because as I said, Primaquine was requiring 2 doses. And so there was this issue of a person not adhering to treatment because someone might get sick, but then upon first few days of treatment, feel better and not completing the treatment. And so the main point about tafenoquine is the single dose, but there is some complexity in the model because we have to describe several treatment regimens, and because some people, they just cannot take tafenoquine due to some risk of adverse effects. And so we did this model, and here I'm showing some points like the effect sizes of reducing the incidence for several municipalities in Brazil, in the Amazon basin, and compared to the baseline. And so the colors here, they describe different scenarios. The main one that I would say is the yellow points and the yellow curve. That is showing the regular schedule, and this is what's supposed to start now. And so what is showing here is that the lower effect sizes that we are expected as we have higher incidences, cities with higher incidences, which makes it difficult, right? So but actually the points that the main message here about this work was that the radical cure could occur, and even from 42% to 62% of cases, leading to a 38% of reduction in transmission of Plasmodium vivax, and more than 200,000 averted cases in the period of 5 years. So this is good news, but it's still not a silver bullet in the case of control elimination of Vivax malaria. And so I think the main points about this presentation are the heterogeneity exhibited in the epidemiology of malaria in Brazil, and the multiple factors should be taken into account when dealing with control, and also several issues related to the clinical treatment and are lately considered, and I discussed the introduction of tafenoquine, but we should also maintain an eye on the surveillance of drug resistance and adherence to treatment. And I am also very interested in analyzing some other factors, for instance, the impact of seasonality in the epidemiology of malaria. I will just acknowledge the great team of students and collaborators that I have in Brazil, and also collaborators from Institut Pasteur in France, especially in the tafenoquine and the epidemiological profiles of malaria, and also some support from funding agencies. Thank you, and I'll be happy to answer questions.
Thank you, Dr. Balela. Very interesting. Do we have any questions? Please fire away in the chat if you want. I'll throw something out real quick. I'm just curious about adherence. And one of the challenges I'm guessing with adherence would be just getting any sort of good measurement there. Is that a difficulty that you face, and can you speak to that?
Yeah, so in terms of adherence, the people in the field, they tell that usually adherence is good. One of these drugs, so the WHO recommends a 14-day regimen, and in the case of Brazil, Brazilian health authorities, they still sustain the 7-day regimen because they want to make sure that people maintain adherence. But you are right, that's difficult to have a good assessment. Well, they say it's good, right? And they have some anecdotal evidence, I think. But if you wanted to do some study rigorously trying to measure, then we have to design something, and this would be very interesting to do. I think it's important, yeah.
Apologies. We have one question in the Q&A from Jacob Barhock, who wants to know, how large are the agent-based simulations?
How large?
Yeah.
But how large in terms of, I'm not sure what he's asking.
The number of participants, the range geographically.
Yeah, this was done for the Brazilian Amazon. I would have to check the numbers, the number of people, right, in the terms of the population. And I remember it was pretty large, but I don't have the specific numbers here right now. So, but
okay.
Yeah.
Another question from Dr. Martinez. What do you think is causing the higher level of heterogeneity with the lower incidence?
Yeah, this is a good question. There's over the years, so we have been observing some lack of investment, and so then we observed some rebound. Some of the cities, the malaria cases were reducing a lot, but then still, we observe some lack of control, and so in some cases this is decentralized. So this could be one of the main points for this heterogeneity. So several states, several municipalities, some of the municipalities, they might attack the problem on a higher standard, let's say, and so this would matter a lot. So.
Okay, great, thank you. I don't see any other questions right now, so I suggest that we move on, and let's hear from Dr. Martinez. You're muted, Dr. Martinez.
Yeah, am I mute now? No.
You're great.
Okay, thank you. I'm sorry for that. Thank you for this opportunity to talk about our recent work on the effect of socioeconomic status on COVID-19 outcomes in Santiago, Chile. And MIDAS, right, includes people that do different type of research. And in particular, my research focuses on understanding the population dynamics of pathogens. And for that, I use mathematical and statistical methods. And in particular, for this talk today, we'll be talking about computational analysis, the access to human movement data, and very good access to health records from Chile. So for this talk, I will be talking mostly about the impact of COVID-19 during 2020. And this picture has two panels. On the left, you can see the country, Chile, right? It's long and skinny. And in red, I am highlighting the metropolitan region, which contains Santiago, the capital. And here on the right, you can see the total number of cases in blue, and then the number of cases on the metropolitan region in teal, and then the rest of the regions in gray. So during this first wave in the winter of 2020, we saw that even though the metropolitan region accounts for around 1/3 of the population of the country, still it was responsible for 2/3 of the overall death. And when we look at the socioeconomic status in this particular area, we realize that Santiago in particular is one of the most dispersed cities in terms of socioeconomic status. So the map on the left is showing the socioeconomic status for different municipalities, where dark green reflect municipalities with high socioeconomic status, meaning high income, high access to good, high education, and access to health. And then in dark red cherry, we see those that have the opposite, less income, less access to education, and less access to health. So on the panel on the right, we just sorted these municipalities from high SES to low SES, and we look what happens over time during the winter of 2020. On panel B, you see the cases per 10,000, and in C, you see the death per 10,000. And here you can clearly notice that municipalities that have lower SES suffer from more cases and more death even after normalized by population size. So we can also look now this kind of association by just pointing the socioeconomic status, that is a value that varies between 0 and 100, and the attributed death per 10,000. And we get this strong association that is significant. When we look at the differences in mobility patterns, we get the same results, in which now the opposite trend, right, in which municipalities with high socioeconomic status were able to reduce more their mobility during the full lockdown of 2020, while municipalities with low SES were not able to stay at home and follow the guidance. And this association is also significant with socioeconomic status. So the main conclusion of this first part is that places with low SES were less compliant to stay at home with the stay-at-home orders, possibly because of unavailability to work from home, which leaves them at a higher disease risk. We then wanted to infer the real number of incidents or the number of cases. And for that, we use a deconvolution process by taking into account the death data, the incidence data, and the infection fatality rate. So having these components, we were able to back calculate what would have been the actual number of cases, knowing that the reported cases is a partial observation of this state. And this is what we see. So here I want you to focus on two main aspects. One is that even though we use 4 different methods, 2 of which were developed specifically for this work, all of them capture the overall trend, and the number of inferred cases is between 5 to 10 times higher than the official reported cases. And the second point is that the methods developed by our group was able to find this kind of early peak at the end of March. So now if we look at weekly data, right, again, sorted by the SES of these municipalities, being at the top, the high SES, we see that during the first month, like COVID was introduced to the country early March, we see that most of the cases were concentrated in these high SES municipalities, and we did not see many reported cases in the rest of the city. However, by looking at the death counts, we see that many deaths occur late March and beginning April, which lead us to believe that there was a very high transmission early on in March that was not captured by the official records. This is supported by the fact that tests the number of tests was also higher in these SES municipalities early March. And then using the convolution method, we were able to infer the number of cases, and you see a much different picture in which now the pattern is much more heterogeneous, and notoriously you can see that the cases were all over the place and not only in these high SES municipalities. So in summary, this epidemic reconstruction reveals early transmission dynamics during March of 2020 in Santiago, Chile. Next, we wanted to measure mortality. And in particular, Chile has an amazing system to record their mortality data. It's highly reliable, is fast, and they explain the cause of death for all the individual deaths that happens in the country. So we wanted to see how many of the COVID-attributed deaths were explaining the excess death that we see during the same period of time. So on the left here, I'm showing the total number of deaths, right? Here we use a Gaussian process to estimate what will have happened in the absence of COVID-19. And this takes into account the growth of the population as well as the seasonal component. And in dark blue, we see the actual observed number of deaths during 2020. Then if you subtract, right, the observed death from the predicted death, then you obtain the excess death, which are shown here in gray on the plot on the right. And you can see that COVID-attributed death falls within the confidence intervals of the excess death until late June. And then these deaths even are higher than the excess death. Now, if we look at these dynamics by age structure, we see that the age group that was mostly affected were those between 60 and 80 years old, and that the association between deviation from the expectation and socioeconomic status was negatively correlated with socioeconomic status in people younger than 80 years old, and those that were older than 80 years old didn't show any association. So overall, we can say that these anomalies in the overall excess death are higher in more vulnerable areas, particularly in people younger than 80 years old. We also went and looked at other type of data that was available. In particular, we looked at testing capacity, positivities, and delay in the results. So positivity refers to the fraction of tests that are positive at a given time. And here you see the temporal trend, which is also highly correlated with socioeconomic status. So basically, places with lower SES, highlighted again in dark green, tend to have a lower positive rate, right? And this association is even is also present when we look at death per 10,000. So a higher positive rate is a good indicator of a higher mortality rate. We then look at timeliness, and timeliness can be understood as the probability of getting the test result within a week. And again, we see this trend that especially during the huge peak that the country suffered in June of 2020, the probability of getting the result within a week was very low, but particularly lower in those places with low SES. So we saw a positive significant association between socioeconomic status and the average waiting time of their tests. And again, this was also associated with the death per 10,000. Finally, we look at other measures, right? It's not surprised to see that timeliness and positivity are also negatively correlated. So higher positivity tend to be associated with higher waiting times or lower timeliness. Tests per 10,000 were negatively associated, and this was kind of the opposite direction that we saw at the early stages of the epidemic, and this makes sense if there are more tests occurring in these low SES places. But then when you actually normalize by tests per 10,000, like the association between tests per 10,000 and death per 10,000, you see this strong positive association. And also when you see the number of tests per death individual, you see the same pattern, that people in high SES have higher number of tests per death individual. So test positivity and test delays were much higher in less affluent municipalities, indicating an impaired capacity of the healthcare system to contain the spread of the epidemic. We finally looked at the infection fatality rates by age and socioeconomic status. So we first infer the case fatality rates because unfortunately we don't have data disaggregated at the level of age and municipality for Chile. So we used these inference methods to estimate the case fatality rate. And that is what we observe in A, right? That is the probability of die given that you have a positive test. And then we look at the infection fatality rate, right? So it's the fraction of people that die having been infected with SARS-CoV-2. And then on the C panel, right, we look at this association by different age groups and comparing, we divided our socioeconomic status into 4 categories, and we compare the highest SES with the lowest SES. And what we found is that for younger people, the probability of dying due to COVID-19 was on average 3 times higher in low SES compared to high SES, an association that was also significant in the groups of 40 to 80, but we did not see an association on those that were older than 80 years old. So in summary, what I show here is like an overall picture of what our study is showing, right? We have this index, right, that describes 3 components: is your income, your access to education, and your access to health. And then you can have 2 different extreme groups, right? One group that belongs to the high socioeconomic status of the city, in which they have access to stay at work, like work from home, reduce their mobility in higher fractions that other people in the city. They have rapid test results. They also have healthier underlying conditions. They have more access to healthcare. They have more access to detect other pathologies on time. They also have more access to hospital beds. something that I didn't show, but I am happy to discuss, which overall is kind of reflected in a lower mortality, while the opposite is true for low SES, right? These people cannot work from home, basically because they have to do types of jobs that require them to be in person. They might suffer from other underlying conditions such as sedentarism, obesity, and other comorbidities that can make them more prone to suffer from a severe disease. They have less access to healthcare, which again, together will cause a higher mortality. And this is not only true for Santiago, right? Like when we were publishing our paper, we saw that more and more we saw this type of outcomes from other places, at least in South America. We see this paper from Brazil, but there is also other papers from Colombia and other places of the world. And finally, this wasn't included in our study, but we see the same trend in the vaccine uptake. So now here you're looking vaccine uptake data from Chile, which has been vaccinated most of the population in a very fast rate, right? And this is data until middle of May. And again, the colors reflect the same palette that I was describing before, in which dark green refers to high SES. So many people in the older groups were vaccinated very fast, and they don't show any association with SES, which is kind of denoted by this not significant p-values association. But if you see here for younger than 60 years old, people in high SES tend to have a higher vaccination uptake, and this association is significant. Now, I'm pretty sure that if this association becomes less significant when everybody gets vaccinated, therefore we have to keep monitoring this, but it's important to take into account this type of information when we take decisions related with who to vaccinate first, where to vaccinate, and so on. Okay, so this study was made in collaboration with people from multiple institutions. Gonzalo and I, and Pablo Marquet we are from Chile, right? Gonzalo is doing his postdoc in Oxford. Aisha is a demographer that helped us with our study, and Mauricio and Caroline are in Harvard HSPH, who helped us to put this study together, who is already published. And with that, I will take any question if there is any. Thank you.
Great, thank you. Any questions for Dr. Martinez? I'm not hearing anything. I will start with what I think is sort of an obvious question. You mentioned how this sort of analysis has been done in multiple places across South America. Is there any reason to believe that we would see anything different if we were to do this sort of analysis for the United States? I'm saying the data sources might be different, but the outcomes, I'm guessing, would likely be similar. And I know I'm asking you to guess, but.
Well, in fact, there are some studies showing that there is a strong association with race ethnicity, which is also highly associated with socioeconomic status, right? I think in our case, we are a very highly homogeneous community. So class is like the difference in class is much higher than the difference in race in Chile. So I think that's why we use this index, but I'm sure that this is true across the world. And in fact, one of the projects that we are doing now is to look at this pattern of the vaccine uptake, because we saw the same in the US that more affluent communities tend to get the vaccine earlier. This was seen also in Israel, who also vaccinated very fast their population. They also saw an association with socioeconomic status. And the question is why? Because it's not that they don't believe in the vaccine. There are many reasons why these more less affluent populations might have struggled getting their vaccine. Many times they don't have the permission to get the time to go and get vaccinated. They have less access because maybe there are less places that have the vaccine. The cost associated, even though at least in Chile is free, but there are many reasons. There are like misinformation, and people believe that this is going to cause them harm because they might be less educated. So there are many reasons why this might be happening. And we are very interested to see if this vaccine uptake pattern is something that we can describe globally and not just in Chile and or US and or Israel. But that's a great question.
Thank you. A couple of other questions here that came in for the Q&A. What relationships do you think the variables considered to have with the impact of the vaccination campaigns?
Well, I guess I addressed a couple of them, right? Like, for example, in Chile, if you look at, or in Santiago, Santiago is not Chile, but in Santiago, which I have been looking at the data, we see that these high SES places tend to have more vaccine places, right? And people, again, if you have to be at work and you cannot take a break of an hour, maybe that's harming your probability to go and take the vaccine, because if you go and there is only one place in your community area and there is a line of 1 hour and you only have 1 hour to take the vaccine, that will probably make you to go home and not take it. But yeah, it's an interesting question, and we don't know, because also that might vary from culture to culture, right? Like the reasons why people are not getting vaccinated in the US might be slightly different of the ones that are in Chile, because there are cultural differences. And for that, we are planning to do a survey that allows us to identify what are these kind of the causes of these disparities.
Okay, another question in the Q&A. Can you use similar techniques to look at US data retroactively and to assess the accuracy of reported numbers?
Yes, absolutely. And in fact, I have to say that from our collaborators, Mauricio Santillana, who together with Gonzalo Mena developed this the method of deconvolution process to look retrospectively the number of the, cases. Mauricio Santillana has been publishing recent papers to show this underreporting scenario for the US. So if you are, I don't know who asked the question, but if you are interested, I will suggest to go and look what Mauricio Santillana has done recently in this, in concern to that.
Great, thank you. Another question here involves the mechanism of vaccine. You know, here in the US, we've seen a lot of these mass vaccination centers have been set up, and also a good amount of it through retail stores, such as the pharmacies. How has the vaccine been distributed in Chile?
Okay, so the vaccine is mostly distributed to health centers. So these are health centers that are in each of these municipalities. So they don't have access, and not that I know of, and maybe I am wrong, but that it is my understanding that you can only get the vaccine if you go to one of these kind of health centers that are like this sort of clinics or like local things that local places that will allow you to get the vaccine, and it's completely free. So you just need to show your ID and they will provide you with the vaccine. Provide you with the vaccine. Yeah.
Got it.
And there is a map. In fact, if someone is interested, well, within the things that Chile has provided tons of data, and there's like interactive maps in which you can actually look at the locations. But again, like for example, in the US, where I am here in Champaign County, in order to get my vaccine, I had to make an appointment online. And what happens with those communities that don't know English, that live in Champaign, it will be much more difficult for them to get an appointment, or if they don't have access to internet. So I am not sure how the situation works in Chile. It is my understanding that you can just show up, you don't need an appointment, but still you need to have the time and be able to mobilize, like be able to commute to get into that place. And many times the waiting times in these low SES are higher because they have less places where they can get vaccinated. But yeah, we still need to disentangle the reasons of this disparity.
Yeah, just thinking about it, it's very easy to imagine that there might be a great many similarities, say, between what went on in Chile and what's gone on here in terms of those dynamics. And I guess the interesting question is to find those differences and to learn from them.
Exactly, and we are working on that. That's what we want to do. We are doing it, yeah.
Very good. Any other questions for either speaker? Happy to bring Dr. Balela back into the conversation if anybody's got any further questions. Well, I'm not seeing much, but I just want to give a final perhaps comment here that builds on my last question, which is to say that you know, to a certain extent, what we've just been through is this sort of natural public health experiment, where we've seen so many places where people have been dealing with COVID and using different policies and procedures to respond. And I think the question of trying to figure out beyond sort of large anecdotes of, you know, such and such a country really did well with X or Y, to figure out the finer points of what worked and why and how we might learn from those is I think an interesting ongoing challenge that these models can help with. And, you know, I think malaria may be less pressing in a global sense, but I think in the same way, though, Dr. Balela's work and comparing what happens perhaps across these different variants of malaria and how that plays out in different places also has some potential lessons that could be really quite useful.
Yeah, I agree, Harry. I have also been working lately on a lot of analysis on the COVID-19 cases here in Brazil, right? But I still think that, well, the study of malaria, I have been looking at this for the past few years, and it's still something of the, let's say, a neglected disease here, right? So it's still the case, and we have been doing a lot of work on, as we were just saying about the interventions for the COVID-19. In the past few years, we have done control in terms of vector control and also these treatments of malaria, and we are still we still have a lot of efforts to be done towards some reduction, some elimination of malaria. So the experiments that we have been in the past months for the COVID-19, well, could give us a hint of what some other experiences that could be done in terms of the malaria and other neglected tropical diseases.
Yeah, and I would like to add to that is like, I really thank this opportunity of MIDAS to create this MIDAS LATAM, Latin American kind of community, because there are like a lot of things that can be done. Like, even though I talk about the high uptake of the vaccine in Chile, and I know the situation is very similar in Brazil, even though the vaccination rate is not that high, we still have tons of cases of COVID, and this situation is very critical, as well as in Colombia and other parts of South America right now. So I think this is a great opportunity for us to work together and like try to see what we can do next. Absolutely.
And I would love to see similar groups of MIDAS and related researchers looking at other parts of the world. I think we can all learn from each other in that regard. Well, thank you for taking the time. Really appreciate both of the talks. And we look forward to hearing from you soon. I know I'll be talking with the MIDAS Latin America folks soon, and we hope to continue to support these efforts and to move forward, see what else we can bring of them. So thanks everybody for attending, and we will look forward to hopefully having you join us in July for the next MIDAS webinar. Thank you.
Thank you. Bye.
Thank you very much. Bye.